Hi team, Charmaine here. Welcome to your first clinical simulation laboratory session. This presentation will go through the theoretical aspects around intravenous therapy. Of course, we had the lecture allocated to this week, and that was about managing fluid imbalance. Now, going into our lab, we're going to visit the theoretical background of intravenous therapy and sort of give you a preview of the practical aspects behind that. And that way, after this, you can go ahead and watch the procedural video, and hopefully that will round things out a little bit more for you. And by the time that you get to your clinical simulation class later this week, you can jump straight into it after going through the clinical case scenario with your tutor. So this is all to help prepare you for not only your lab session this week, but all the classes where we will build on this foundational skill. We'll be looking at different forms of IV therapy over the semester, and then, ultimately using this on clinical placement and applying this skill to many different clinical situations. Okay, so intravenous therapy. The goal of IV fluid administration is to correct or to prevent fluid and electrolyte disturbances. It allows for direct access into the vascular system, permitting the infusion of continuous fluids over a period of time. IV fluid therapy, then, of course, must be closely regulated because of those continual changes in a patient's fluid and electrolyte balance. When IV fluid administration is required, the nurse, of course, must know the reasons for the prescription of the particular solution and the amount, the correct prescribed solution, the equipment needed, the procedures required to initiate the infusion, how to regulate the infusion rate, how to maintain it, how to identify and correct problems, so troubleshooting, and when and how to discontinue the infusion when that's necessary. So this slide is just sort of orientating you to the content that we're going to cover in Nurse 5084. We're looking at acute care in Nurse 5084, and so we're looking at intravenous fluid infusions as part of the parenteral routes of administration. Now next week we're looking at another couple routes of parenteral administration, and that is IM and subcut injections. Parenteral referring to the administration of medications that aren't through the gastrointestinal tract, and because it's IV, intramuscular, and subcutaneous, they do involve the piercing of skin to get into body tissues. Now, under intravenous fluid infusions, we branch off into these. Let's start here: a macro set and a micro giving set. You'll see here I've put there that these are both gravity sets. What that means is that the fluid is going to run through the use of gravity. This is as opposed to the one here on the right, which is an IV fluid administration or fluid infusion through an infusion pump. It uses a machine to regulate how fast or slow the infusion will run. If we go back to the left and to the middle, between macro and micro being gravity sets, it requires the nurse to regulate the infusion. And the way that we do that is through a mechanism called a roller clamp. And we release the fluid or stop the fluid through the control of a roller clamp. And we have to actually watch how many drops are dripping within a minute. And so it requires the nurse to regulate the flow rate, how fast or slow the fluid will be administered manually. So we're using a nurse's watch. We're carefully watching the drops per minute, the rate of infusion. Again, this is as opposed to an infusion pump, which uses a machine to regulate that infusion. So we first start off with a macro set. This is what we're doing this week in the labs. A number of weeks from now, we'll go into giving IV fluids through a micro giving set, and administration of fluids through an infusion pump. So we'll cover all of these things as part of the content in Nurse 5084. So with this week, using a macro set, we're going to administer a bag of intravenous fluid through the intravenous route. We need to use a formula in order to be able to calculate the drops per minute flow rate for this giving set and this bag. We also can give through a macro set IV fluids that have inside that bag a mix of IV medication. So you draw up the IV medication in a syringe, you inject it into a bag, and then you slowly infuse it into a patient through the intravenous route. So you have a couple of different options there. Again, we'll be doing both of these things. This week we start off with just administering the IV fluid bag without any IV medication mixed into it. Now, when we do go into an IV medication mixed into a bag of fluid for administration, we will go through that in week 3. And the reason why we visit these so early is because this is a foundational skill that will help prepare you for this skill. And this skill is the one that you'll be doing for your clinical performance appraisal, your CPA, in week 11. It's the practical assessment. We do a micro giving set, and it has a different formula from giving an infusion through a macro set. And when we infuse using an infusion pump, again, a different formula. And you would have watched in my introductory overview or orientation lecture to the unit that you have a medication calculations assessment online through Canvas, and it will require you to use a number of different formulas in order to calculate drip rates and just overall correct dosages for patients. So let's start off with gravity infusion set. So here you can see what I was describing before. The nurse who's got the bag of IV fluids at the top. This is connected to some tubing, which will be eventually connected to the patient's cannula. And you would have seen those and heard that term cannula while you were on your clinical placement periods. And if it's something that people didn't go, or nurses didn't go into depth with you, we will visit cannulas a little bit more. So here you can see this is what we call the drip chamber. We've got an IV pole. The IV bag of fluids is hanging off the IV pole. This is the handle where you can sort of make the pole higher or lower, and that will change the speed of the drip rate as well, or affect the drip rate. In this drip chamber is where you will see the fluid dropping, and you count how many drops fall in 1 minute, and that's why we have a drop rate of drops per minute. So you have to stay there, count, watch carefully, both your second-hand watch and your drip chamber. And in your dominant hand, you want to hold the roller clamp. So I described that to you earlier. And this is what's going to regulate how fast or how slow, or you could completely stop the infusion using this roller clamp. It just requires you to slowly release with your thumb up or down, and that will either speed up or slow down or completely stop the rate. And even though I can sort of describe it to you here, is going to make a lot more sense once you watch the procedural video and once you actually practice it yourself under the close guidance and support of your class tutor this week. To the right of this slide, I want to show you the difference between a macro set and a micro set, especially with regards to the calculation and the formula that you'll be using for these two gravity sets. Now, a macro giving set has a drop rate of 20 drops per mil. Some giving sets, in very rare cases, will give 10 or 15 drops per mil. but otherwise the most common drop factor for macro sets is 20 drops per mil. And I'll show you where to find this on the packet before you open the giving set. Now a micro giving set delivers 60 drops per 1 mil. And so always remember that the drop factor for a micro set is 60 drops per mil, and unless otherwise indicated or stipulated, the drop factor for a macro set is 20 drops per 1 mil. So here I've got a number of pictures. This is what a macro giving set looks like. So here you have the spike. This is what will pierce the IV fluid bag through the port, and I'll show you what that looks like as well in the following slides. So underneath you have the drip chamber that needs to be eventually filled with fluid, but part of it needs to be not filled with fluid so that you can actually see the drops dripping through the drip chamber. This part is the roller clamp, and so as you release or open the roller clamp, it speeds up the rate. As you close it with your thumb, it will slow it down or completely stop the rate. It's how you regulate the rate of infusion. Now, filling this line with fluid by slowly releasing the roller clamp is described as priming the giving set. So once the giving set is filled with fluid, it is primed. Now this end is what is connected to the patient's cannula. There is a cap or a lid on this patient end, as you will find a cap also sitting on the spike end. This is to maintain sterility of both ends because we don't want to introduce any harmful bacteria or microorganisms to the patient's circulatory system. So there's always a cap over this spike that gets spiked into the bag, and there's a cap on the patient end which connects to the patient's cannula, which is sitting in a peripheral vein. Now this patient cap end must stay on right until you are ready to connect it to the cannula. So leave it on even when you're priming, please. This is just to show you that cap that would usually be on the spike, but giving sets can be many different types of colors depending on the manufacturer. Now I realize that my little video screen is sitting on top of something that we need to look at, so I'm just going to move that there. Here is the outside of the packet of what we use here at our nursing school. So when you are using a macro giving set, this is what you'll collect. It is possible to administer blood through this giving set, but otherwise we can also just use it as a plain macro set, and that's indicated by this icon. And see here it says 20 drops per mil. And remember what I said on the previous slide, that is the drop factor for a macro set unless otherwise stipulated. So it is a macro set delivering 20 drops per 1 mil. You can also see the expiry date of sterility next to the hourglass. And so expect to see that packet in class this week. Now a micro giving set. You'll be able to tell a micro giving set because it's from a macro because it's got this large section called a burette, and that's a chamber where you can actually determine an accurate volume of fluid that you're administering at one time. It also allows for the injection of IV medications to be injected into this port and mixed into the burette. So just think micro giving set, there is something called a burette. I can accurately see how many mils is in there, how much I'm giving at one time, and I can mix medications into this burette. Otherwise, it's quite similar to the macro set in that there is a spike that gets connected by piercing an IV fluid bag through the appropriate port. There's some roller clamps which will determine the rate of infusion or stop it altogether. There is a drip chamber underneath the burette. You see this grey line here, that's where those drops will be dripping, so that you can see how fast or slow the infusion is going. That line will need to be primed in that it should be filled with fluid slowly by releasing the roller clamp. There is this funny little port here, and you can find this on many different giving sets, and that allows you to do an IV injection of a medication. If you keep going all the way to the end, that is the patient, and that will be connected to the patient's cannula, giving access to the veins. There is still a cap or a lid sitting on that end, and again that must only come off just before you're ready to connect it to the patient's cannula in order to maintain sterility of that end. Now this is the packet that you'll see for a micro giving set. It will have an icon which says 60 drops per 1 ml, and so that'll tell you that it's a micro giving set. It's got a 150 ml sized burette, and the expiry date is next to the hourglass. And then it's also got some indicators for how to prime this line, but it's quite similar to a macro set. This is just to elaborate a little bit more on micro giving sets. We're going to look at this more closely in week 8 of the semester. This is just a graphic to show you the different parts. The spike, this is not an accurate representation of what is like a plastic hook that we can bring up over the IV pole. It'll make much more sense once you see it in real life. Again, this presentation is just to help prepare you for the demonstration and then the subsequent practice. A roller clamp, the burette where we can inject medications in there. There is in every burette something called a flange. It's basically just to indicate, it's colored, the ones that we have are blue. It's just to indicate at what level the fluid is sitting, and it floats to the top as you fill the burette with fluid. The drip chamber, so this is where you'll see the drops coming out per minute, and that's where you'll have to count. A roller clamp, an IV port where we can inject medications, but we're not doing that this week or in week 8, and the eventual patient end connector. This is what an infusion pump giving set and machine will look like. It will be quite similar to a macro set. The only thing that changes in terms of the giving set is this part that actually goes into the machine, and they will be indicated through color, and this will make much more sense once you actually see it in the labs in week 4. It's just we do the same procedure as for priming. It just, instead of setting the rate with a second-hand watch, you'll be placing the giving set into the machine and setting the rate manually. Setting the rate through the buttons on the machine, and you'll see that indicated on the screen. So it'll say how many mils per hour the infusion is going at, and it still allows for the patient to be able to be ambulatory. They can walk around the ward still with the machine, but it does otherwise need to be plugged in once the patient's back to bed. The positive thing about sort of the pros about using an IV infusion machine, like the Volumat Agila machines that we have at Union and in a lot of the hospital where I work, and also at Westmead Hospital, they use these giving set machines in acute care settings on the wards. The good thing about using these is that it has a sensor, that if you start, if there is air in the giving set, it will detect that and it won't allow the infusion to continue. And that's the risk that is run when you have a gravity infusion set. There's nothing to detect the presence of air in the line, except for usually the nurse, to visualize that there is air in the line, stopping the infusion and eliminating that air before any infusion can continue. And that's dangerous because it can create an air embolus. So the relevant formulas for IV infusions for macro giving sets, remember that the drop factor is 20 drops per mil. It is volume in milliliters over time in hours divided by the drop factor, which is 20 drops per mil, over 60 minutes. Now the denominator in this formula is there in order to give you time in minutes. So time in hours multiplied by 60 minutes gives you time in minutes. Remember that because sometimes you have something where it says, 120 minutes. In that case, you just leave it as the denominator as 120 minutes. You don't need to put the time in hours and then multiply it by 60. You just need time in minutes, and that's what this bottom formula gives you in the denominator. And once you calculate this rate, it will give you drops per minute. So gravity sets are always drops per minute, and you will have to manually set the drip rate by looking at the drip chamber, slowly releasing the roller clamp, and comparing your drop rate to a second hand on a watch or a clock. Now, micro giving set formulas only change with regards to the drop factor, which is 60 drops per 1 mil. You still need volume in mils divided by time in hours, the drop factor, which is 60 over 60 minutes. Again, this bottom denominator formula gives you time in minutes. If you have, usually with micro giving sets, because it's 60 drops per mil over 60 minutes, these cancel each other out, and it ends up being just volume in mils divided by time in hours. And that will give you, again, drops per minute. Gravity sets are always drops per minute and require the nurse to manually set the drip rate. Infusion pump giving sets will give you a rate of mils per hour. If you remember that image of the infusion pump, the rate was going through mils per hour, not drops per minute. And that's really important that you remember that because any of your calculations for your medication calculation assessment, your unit of measurement must always be included. So if your answer is 250, is it 250 drops per minute or is it 250 mils per hour? So always remember to include the unit of measurement. This drip rate is then entered into the machine, and that machine can deliver that fluid at that set rate. You don't have to stand there and count the drops per minute through the roller clamp in the drip chamber. The documentation. So this, if you remember in Nurse 5082 in that semester, you had a CPA, or a clinical performance appraisal, that required you to administer oral medications, and you had a medication chart, and we'll still be using that this semester, but mostly for IV medications. But now we also have a fluid order form. Excuse me. And this fluid order form is the one that we'll be using this week and throughout the semester. We've got our patient identification information at the top, so we can do write patient as a write by comparing the patient's verbal response when we ask them, can you tell me your full name and date of birth? And then we check the MRN and compare the MRN from the patient's armband to the chart, and we ask for allergies, and this patient has nil known drug allergies. And then we've got the actual prescription. Now, something that I want to make really clear is that there is no time of administration. There's nothing that's going to say, at 8 o'clock this needs to be administered. It's not like the oral medication prescription where it says, at 8 o'clock give your metoprolol. So it doesn't have a time of administration. but it does have the date of prescription, which we need as part of a legal and valid prescription. We still need to do that. So it still needs to be written in black ink if it's not, an EMR prescription. Written in black ink, we have everything that's legible. Over here is where we'll find the prescriber's name printed and their signature. We've got their contact details, but in terms of legality, written in black ink, signed by the prescriber, dated by the prescriber, and it's legible. Last semester we had our 5 rights 3 times. So we've got here right patient, which we can check verbally with the patient, check it and compare it against their identification band and the documentation here. Associated allergies, it's part of identification. Last semester we had right medication. It is now right fluid, so fluid type, normal saline, 0.9%. And that can also be just written as normal saline. Last semester we had right dose, and now it is right volume, so 1,000 milliliters of normal saline. Last semester we had right route. Now right route in this situation will always be intravenous, so IV is written here. And right time or frequency is now right rate or duration. Because remember, there is no time where it's specified that it needs to start, but we have the right rate or duration. So the rate here in mils per hour is 125 milliliters per hour, and then they can also state for how long they want that to run over. So it might be, for example, 1,000 milliliters at a rate of 250 mils per hour, and that needs to go over 4 hours, things like that, or 125 milliliters per hour running over 8 hours. This part of the 5 rights, because it's now right, rate, and duration, will also include your calculation. Your calculation in that you might have a prescription for mils per hour, but you have a gravity set. You don't have a pump set. Remember, gravity sets are drops per minute. Infusion machines allow you to give mils per hour. And what happens if you don't have an infusion machine, and that happens sometimes, is that you need to use a gravity set. And so you'll have to convert from milliliters per hour to drops per minute. So we're going to look at that in the following slide. And this was just to kind of orient you to right patient, right fluid, right volume, right route, and right time/duration, and of course the legalities of the prescription. So when you're going from milliliters per hour to drops per minute, the example I gave you before is when you have a prescription that says 100 milliliters per hour, but you don't have an infusion pump. You do have a macro giving set. So while we're waiting for a machine to become available, or maybe we just don't have any at all, then we're going to use a gravity set. So we need to firstly calculate time in hours. So the first step is here on the left. We will need volume in mils divided by time in hours. So is it a 1 liter bag? Will be 1,000 milliliters. The rate, for example, 100 milliliters per hour, and that would be here. So 1,000 mils divided by 100, and that'll give you 10 hours. Once you have the answer of hours, that's what you'll use in the formula for gravity sets. Remember, we want drops per minute. And that formula was volume in mils divided by time in hours, which is the answer we got from using this calculation here, multiplied by the drop factor divided by 60 minutes. The denominator gives us time in minutes. Make sure that your volume is really in milliliters and not liters, and you apply your relevant drop factor. So if it's macro, the drop factor is 20. If it's a micro set, the drop factor will be 60. And this will give you drops per minute. And then remember that for gravity sets, you manually set the drip rate, and you count the drops that fall in 1 minute by comparing the drip chamber to a second-hand clock or watch. So remember before when I spoke about spiking the bag in order to prime the line? This will show you an IV fluid bag, and it says here, just so you can see one, normal saline or sodium chloride 0.9% for intravenous use, in very small writing, but it's for intravenous use, so you can compare the route there as well. And you can see the volume in big letters, which is 500 milliliters. And on the bag it will also have expiry date. Now, the fluid bags have two ports. The port that's usually on the left, or one of the ports, one of the two, is for injecting into the bag. The other port is for connection to an IV fluid giving set to be primed with the fluid and connected to a patient's cannula. Now, syringe, this is not a great image, but it just shows you that at the bottom of the bag there is a white port that is indicated by an upward arrow. You flick this off the bottom of the bag and it's just left with just the white indicator, and this is where IV medications can be injected into the bag. Now, pay no attention to the syringe just hanging out of the bag. It's not a very good indicator. We never just leave syringes and needles hanging out of bags. It's just to indicate that this is for medications going in the bag. The blue one has a tab, a similar tab to this one, but the arrow is pointing down, indicating that it's for outflow, not inflow. So this is where the spike end of the giving set, a macro or micro or an infusion pump machine giving set, it will be spiked here. You fill the drip chamber with fluid. You slowly release the roller clamp in order to prime the fluid line that eventually gets connected to the patient's cannula. So just keep in mind that we have these tabs. White, an arrow pointing up, is for injection into the bag. Blue with an arrow pointing down is for priming infusion lines to administer to a patient, so coming out. There's a lot of different types of or ways of giving infusions and medications. This is to show you a piggyback line, and that's what it's called, piggyback. It means that you have one line that's going into a patient, but there's a port on the giving set that allows for either injections, IV injections, or you can actually connect the patient end of another giving set to that port, and then you have two bags hanging, two lines that are primed. One is piggybacked onto the other by connecting the patient end to the IV port, and then you can give one at a time. It means that you have two different bags of fluid having their separate lines, but eventually going through the one line, and you can use the patient's cannula. It means that you can turn this one off or shut it off, clamp it off, open this one instead, and usually the one that you're administering that's actually going through that you haven't stopped, you will need to put a little bit higher than the one that you have stopped. So in this situation, this is the primary set. This is the bag that was hung. It was spiked. The line was primed, connected to the patient's cannula, and then this is the bag that's piggybacked. And so they've done the same, but they've connected it to the IV port. And whichever one you're delivering, you open, and the one that you're not delivering, you clamp off or shut off, so it's not running. And so things can run straight after the other. Now, we're not using this at uni, but when you go on placement, this is just so that you're aware that fluids are prescribed through e-fluids when there's an EMR system. So, for example, a lot of metropolitan hospitals now are using EMR, not paper-based forms for a lot of their procedures. So e-meds, for example, we're not using those paper-based medication charts in most places, but they're using going through the EMR. Similarly with fluids, there's e-fluids, and so it will give you the prescription. And so I just want to show you what that looks like so that you're somewhat prepared to see that. So it'll tell you the name of the medication, if there's any additives, what that additive is, the volume of fluid that they're giving, and it's for continuous infusion at a rate of 250 mL per hour over 4 hours. So we have rate and duration, and again, if there's any additives, we're not doing that this week, in week 1. This just shows that it hasn't started yet, and so this is the fluid bag that you'll be starting. This is what you'll see once you try to start the documentation. So it'll give you a date, the time, your name will be there once you're logged in with your access, witnessed by, because IV, anything in parenteral routes have to be checked by 2 nurses. So you have your witness there, and then once you start typing their name, you find the nurse and you click that one. The site, so which particular cannula site is it going through? Is it the one on the right? Is it the one on the left, for example? The volume you can place in there, so 1,000 mL at a rate of 250 mL per hour. And this will show you one that's already filled out. So you have the date, the time that it started. You place in the time that it started. It's not prescribed to start at that time. Your name here. The person who's witnessed it and checked the bag and checked the expiry and checked the prescription, what number bag it is, the site, the volume, and the rate. So, the Australian Injectable Drugs Handbook. I find that a lot of students, every year that we do this, no matter if it's the BN or the MN cohort, they're always really reluctant to refer to this drug handbook as if it's something that's really intimidating. I don't want it to be intimidating. It's basically like a recipe book. It will tell you, with a recipe book, you look up the recipe that you want to, cook for your meal. Gives you a list of, a procedural guide, a step-by-step guide of things that you'll need, the steps that you'll do it in. And it will give you precise, degrees for your oven and everything like that. This is just like it's a guide, and it gives you your recipe basically for mixing your injectable drugs. So this is made by the Society of Hospital Pharmacists Australia. You will also have seen this same society published Don't Rush to Crush, the blue version of this book, which is about whether you are able to crush a medication in order to administer it through a different route or not. So these are the same people that make that, and that would have been described in first semester in 5082. So it's got over 500 injectable medications, and it gets updated quite frequently. You can access it through the online through the library website. We have printed bound copies in the labs, but I always think, when I'm working clinically, I just look it up on the computer. It's easier than flipping through the book, I find. Sort of similar to looking up MIMS. You're going to look through the printed book, or you're going to look at the computer. Either one is fine, but I just find typing it into the search bar and then being able to come up with the medication is quite good. So this will, once you find your medication, you search for it, it will give you the synonyms, so other names of the medicine, including the full Australian approved name. It will give you the brand name, so remember that there's differences in brand name and trade name or generic name. So you have the brand name or the generic name. It's also going to give you the availability of the medication, so how you can find it. So it might be that it's a powder form, it's 5 milligrams in a vial, that kind of thing. Gives you any relevant warnings if there's any potential for harm to a patient that needs to be considered before giving it to the patient. So maybe if they've got if it's contraindicated antibiotic for people with a penicillin allergy, that kind of thing. It also then tells you how to prepare the medication. So it'll tell you to reconstitute the powder by diluting it in a particular solution. And so this is what I mean by it's almost like a recipe book. It will also talk to you about how it's administered. So it will give you some options. It can say that it's suitable for intramuscular injection but not suitable for subcutaneous injection, or it's suitable for IV injection but not suitable for IV infusion. Now, injection referring to that once-off push through a syringe, or an infusion where it's going through the patient's cannula slowly over a certain amount of time and it's more diluted. It will tell you exactly how to prepare it, what to prepare it with, in how much volume, and I think the intimidation really just comes from having to follow all the different steps. But I promise you, once everything is broken down, and this is the purpose of this is the purpose of having your labs, that you practice it, you make mistakes, and you get feedback, and you correct those mistakes. You'd rather make mistakes in your sim labs, and this is something I always say, you'd rather make mistakes during your simulation classes than make them out while you're on clinical placement or after you're registered. So feel free to make mistakes and get them corrected, and get feedback on your practice from your tutor and from your colleagues, because this is how you improve, through practice, time, and exposure. It will also tell you, this book will also tell you, what you can't mix the medication with, so incompatible fluids, and what it can be mixed with, so compatible fluids. This will make much more sense once you do it. Please don't be intimidated by it. Your tutors and the teaching staff and your facilitator, and they're all there to support you in your learning, and we want you to be well-prepared nurses. So if you need to revisit this presentation, please do so. You have the slides on Canvas, access throughout the whole semester, including on when you are on placement. You can watch the procedural videos, and you can get feedback in your labs. Just lots of practice. Go to your practice labs as well, and ask lots of questions. It's fine. This slide just shows you diluent and medication vials to show you what it looks like, basically. You'll be familiar with plastic ampules from 5082 when you were doing the aseptic non-touch technique of a simple wound dressing, and you had to open the irrigation solution that you were going to clean the wound with. It's the same sort of thing, but these are for injection. It says there on the packet. So water for injection or sodium chloride for injection. It tells you the milliliters, the volume, and it tells you the expiry date as well. And this is a medication vial, so when we start to mix medications up, we have this lid at the top, and inside is a rubber stopper, which we often will just clean with an alcohol swab to just to clean it a little bit more in case our fingers came into contact with it. And it tells us all the medication information, so we can check correct dose, correct route, it will be on there as well, correct medication, correct route, and correct dose. We will also be able to check correct expiry date on the vial. Now, when we're mixing medications from week 3, this shows you the vial that we'll be using. In clinical practice, anything with glass that is single use only, we place into a kidney dish and place into the sharps bin. At uni, we'll be recycling just these glass vials. And there's a equipment recycling maxi bin in every lab. Just remember, these glass vials we recycle, but in clinical practice we just place them into the sharp spin. So please remember that, and your tutors will remind you in class as well. This is where we can draw up a diluent in our syringe, attach a way to access the vial, mix the diluent with a powder, and then draw it back into the syringe. And then this syringe will change the needle and inject that into the bag. If you remember from a few slides ago, how you could inject into a bag through one of the ports. This is a vial access cannula. This is what we use at uni, but it's not always available in every clinical hospital or clinical setting or hospital. But a vial access cannula means that you can attach this to a syringe. It's not a sharp, but you can use it to pierce the rubber stopper at the top after you've wiped it with an alcohol swab, inject the diluent, and then when you retract or pull the syringe out, all that will remain is this piece of plastic. And that's good because it means one less sharp and less risk associated with the procedure that you'll get a sharps injury. Just remember that if you're trying to then inject into a bag, you need to remove this piece, and the way that you'll do that is by putting the lid back on and then unscrewing it, because it's a lower lock mechanism. And something that you'll learn in next week's presentation about injections, IM and subcut injections, is the difference between lower lock and lower slip. That presentation is already available on Canvas, so you can go ahead and have a look. So when we're adding IV medications to an IV bag, which remember is your skill, one of your CPA skills for this unit at the end of the semester, there is no fluid prescription. There is just the medication prescription. So there's no fluid order chart that will tell you we need to give 1 gram of cefazolin in a 100 ml bag. It's just the medication prescription, because it's considered it's considered part of the prescription when you read it in the Australian Injectable Drugs Handbook. Now, you still have to document that you gave it, so you still have to document in the medication chart that you gave the cefazolin 1 gram, and you have to document in the fluid balance chart, something that you looked at in a tutorial in 5082. You still have to record in the fluid balance chart that 100 milliliters was administered to the patient as part of giving that antibiotic or that medication mixed into a bag. Again, it will make much more sense as we start to put together this theoretical overview, the procedural video, when you get to your lab class and you start to actually do the procedure, and as you practice throughout the semester, this will make more sense. But I would need to let you know that even in clinical practice, they won't have a fluid order prescription for when you're mixing IV medications into an IV fluid bag. It is just the medication prescription. And so the example that I have here on the screen is from the EMR, and just to show you that, this is an example. We've got the medication ceftriaxone 1 gram intravenous, prepared in a vial. We're giving it for these reasons for this patient. Mix it in 50 milliliters of normal saline, infuse it over 30 minutes, and then your name will go here, your second nurse will go here, and you can actually, it prompts you to tell you, it prompts you to enter how many milliliters it was given in. So if you go to the Injectable Drugs Handbook, for example, and it says you can give it between 50 to 100 milliliters, and you ended up giving it in 100 milliliters, it's fine. It's still a prescription as per the Australian Injectable Drugs Handbook. It's appropriate, and you can just place the milliliters there. From there, it will document that you gave this medication, and in the fluid balance chart, it will automatically place the time and the volume and the type of fluid that was given So it's all going to correspond across all the documentation. It's okay. For IV medications mixed into IV bags of fluid, it is just a prescription for the medication, not a separate fluid order chart. So you only look in one place, the medication chart. So this is just going to remind you of that. And you can revisit, as I said before, you can revisit these slides. You can ask questions to your tutor or me, or the discussion board, and we'll answer that. Now in Australia we have labelling standards, and I'm going to show you what these labels look like. But just know that incomplete or inaccurate labelling of injectable medicines and fluids is recognised as a risk in the safe administration of medications. So we have this labelling standard to help other practitioners identify medications that have been removed from their original packaging, to promote safer use of medications through standardization of best practice. And while each healthcare facility has their own policies and procedures, this is standard across Australia, and this is to promote safety in relation to injectable medications. There's always potential for error when you have variation of policies between facilities, so having these standardized labels provides a system of safer administration. This will show you the labeling that we place on patients that have IV fluids running. We are meant to place a label near the injection port on the that is closer to the patient's side and connected to the cannula, and that needs to have written on it, the date and time that it was commenced. At uni, we don't have those small labels, but we do have these bigger labels. So when you attach a label on a burette because you've mixed a medication into here, we'll need to complete this label. We'll prompt you to indicate the patient's name, MRN, their date of birth, the medication, the concentration, signature, and the second nurse or the checker's signature there. The one that you'll be using for your CPA is this label here, for intravenous use only, because we'll be adding a medication to a bag for your CPA, and that will be covered in week 3's lesson in the lab. You'll still have to complete the same information: the patient's name, their MRN, their date of birth, the medication, the dosage, the volume of the fluid that you've mixed it into, and therefore the concentration. So if it's cefazolin 1 gram in 100 milliliters, it's just 1 gram in 100 milliliters. The diluent which you initially mixed the powder with, so it might be 10 milliliters of water for injection. The date, the current date, the current time, your signature will go here, and the second nurse who checks that fluid, the medication, and the diluent, and the prescription for all of that, puts their signature here during the second check. This will just show you how a patient acquires peripheral venous access, and it's through a cannula. And you would have seen this on your clinical placement periods. A cannula is inserted through the use of a sharp. Now, doctors and nurses can do cannulation. I've done the cannulation course. Cannulation course is done through your health facility that you're employed at, and it just requires a sharp to be inserted into a peripheral vein. What gets left behind, though, is just a flexible piece of plastic tubing. The sharp is removed, and the site is secured with a dressing. And also the actual hub of the cannula is connected as a way to prevent backflow of blood coming out. So that's like a one-way valve, but it's the whole thing collectively is the patient's cannula. So when people say, oh, we're going to put this we're going to connect this to the needle in your arm, make sure that patients know there's no needle. That was what was used initially, but it was removed. And now it's just a piece of flexible tubing. So Here are the common sites for cannula insertion. When it's inserted into a vein in the patient's cubital fossa, that's when it can become tricky in terms of consistency of infusion rate, because if the patient bends their arm, which they're often doing, to eat or, just, to move around in bed even, it can then become temporarily occluded. You're temporarily occluding that vein, and so the infusion can be stopped intermittently when it's in that area. So most commonly you'll see them in the dorsum of the hand. Here you can see part of the cannula is out of the skin. Underneath this dressing is where the one-way valve has been connected, and from that one-way valve, the cannula and the actual one-way valve that's attached becomes collectively known as the patient's cannula. Then you can see some IV tubing is connected here and connected, to the patient's cannula. That occlusive dressing is placed on top. It's clear so you can still visualize the surrounding skin to look for any complications. And we just need to always refer to local hospital policy around how often cannulas are resited or changed. So, typically that's somewhere between 48 to 72 hours that a patient's cannula can stay in that site until it has to be resited by someone who's accredited to do cannulation. This is just to show you how to secure the tubing. Make sure that you secure the tubing by looping it around so it's not pulling on the patient's cannula. So loop it around in a U shape and then place some tape over the rigid part of the patient's cannula and the other side of the tubing. Leave any IV access ports on the tubing exposed so that's easy for a clinician to access, and try not to only tape over this end here because it tends to change the position of the cannula. So if you tape it over here, then it affects how the rest of that piece of tubing that's in the vein sits as well, so it can end up resting a little bit more closely to the vessel wall. So these are just some small tips about how to maintain good cannula access. Here is a type of cannula port. This is called a smart site cannula, and what you'll find is this blue part here is like a squishy piece of plastic, and it needs to be swabbed with with an alcohol wipe before connecting the IV tubing to that cannula. This is another type of valve that sits on the end of that it gets attached to the patient's cannula, again collectively known as the patient's cannula. But so you know the different types, where the other one, which was the smart site where you have to swab with normal saline, this one is a SAF site and requires you to put a cap on the end when it's not being used. So if there's not a continuous infusion running through, it needs a cap, and they come as individually wrapped caps in sterile packages, and it needs to be replaced anytime one is taken off to be able to access the cannula. Some complications that can occur with cannulas: a cool, clammy, or swollen and sometimes painful insertion site could signal infiltration. It's also known as a cannula being tissued because the cannula has dislodged from the vein and it's now in the subcutaneous space or the surrounding tissue space. And so when the cannula is tissued, the IV infusion needs to be discontinued and a new cannula needs to be inserted. When you have a patient who is having intravenous fluid therapy, then you should come back to assess the site and the infusion, that it's running correctly, and every hour, at least every hour, come back to check on the infusion and the site. So we're looking and feeling for any localized coolness and swelling for when the patient's cannula is tissued. You also have a term called extravasation, and extravasation is when there's an unintentional administration or leakage of a solution or medication into the surrounding tissue. It's kind of similar to tissue, but when we talk about extravasation, we're usually talking about that the medication has seeped into the tissue, not the fluid. But either they're both interchangeable, and you'll hear it more termed as more commonly as tissued. If the medication or the fluid becomes an irritant, it can cause pain and burning at the injection site, and so you might have also signs of inflammation. You can really damage the tissue in some cases, especially if the medication really is not intended for tissue. It's meant to be in the patient's circulatory system, especially in the case of cytotoxic medications. You can end up with tissue necrosis if the cannula ends up being tissued. So some symptoms or signs that you can look out for: if the patient complains of pain, burning, or stinging at the site, and the signs of swelling, redness, and leaking around the site as well. Phlebitis is also a complication that can occur. It's inflammation of the vein. So this might happen from the way that the cannula is handled or moved, which is why securing the tubing with tape correctly is important. Signs and symptoms include pain, increased skin temperature over the vein, and in some instances, a red traveling or tracking along the path of the vein. As with all complications, the IV therapy must be discontinued and a new cannula site inserted in a different vein. So with potential complications, when we're assessing IV sites, we're looking to see if there's any swelling. We're asking the patient if it's painful, and we're feeling for any localized coolness that might indicate that it's tissued, any localized warmth that might indicate phlebitis or inflammation, red tracking up the vein for phlebitis, and bleeding. You'll see obviously blood around the cannula insertion site. Similar with leaking, it'll be quite wet around the cannula site if it hasn't been secured properly. Potential sources of infection when it comes to cannulas is, there's lots of different sources it could come from, but you need to be careful with the way that you handle the cannula. When we're attaching the patient end of the fluid tubing to a patient's cannula, we're wearing gloves. We will use our 5 moments of hand hygiene as always throughout a procedure. We use an antiseptic swab on the cannula before accessing it. We maintain sterility of the port on the IV fluid bag that connects to the spike on the fluid line. So there's a lot of ways that we try and prevent these sources of infection happening. This is to show you, a particular type of manufacturer makes their bags slightly different, but there's always like some kind of tab or covering over the access port where the fluid line will be spiked and connected. And so once that is flicked off, we don't touch this end, and once we take the lid off the spike, we don't touch this end. And so in this way, it's a non-touch technique. Similarly, if the bag is already hanging, and that's how we spike the bag, we take off the cap or the lid from this port on the fluid bag, we take off the lid from the IV tubing spike, and we don't touch either of those ends. It's an aseptic non-touch technique. This is just to remind you that we have gravity infusion sets. So this slide was from a bit earlier, and once everything is set up, we've already connected it to the patient, and everything's primed, filled with fluid. That's when we set the rate. So we've spiked the bag, we've primed the line, we've swabbed the patient's cannula, we connect the primed IV tubing to the patient's cannula, we secure it with the tubing, with some tape, and then we can go ahead and set the rate manually, which again is when you hold the roller clamp in your dominant hand. So you can see the nurse's hand here in the image that's holding the roller clamp, and moving that roller clamp up and down to open and close to speed up or slow down or completely stop the rate of infusion. So you're looking for the drops dripping here in the drip chamber, comparing that at eye level with a second hand. So usually your nurse's watch will suffice. Be certain that your tubing is clear of any air and air bubbles. To remove small air bubbles, we just firmly tap the IV tubing where the air bubbles are located, and then you'll watch those air bubbles rise through the tubing. Just make sure that it's all removed, because large air bubbles can act as an air embolus, and so it's just another one of those responsibilities. Here's another slide about some things to keep in mind. We need to make sure that our prescription is legal and valid, written or printed in black ink, signed by the prescriber, dated by the prescriber, legible, and it has the 5 rights. In this case, it'll be right patient, right fluid, right volume, right route, which will always be IV, and right rate and duration. We don't have a prescribed time for IV fluid to start. The only time that this changes is if we're giving an IV medication that's diluted in an IV fluid bag. There will be no prescription for the IV fluid. It is part of how to prepare the medication, and that's what you find in the Australian Injectable Drugs Handbook. So remember, for your CPA, you're doing the skill of adding an IV medication to a small bag of IV fluid. You will just be using the medication chart. There will be no prescription on a fluid order chart for that. The fluid order chart is for large amounts of fluid, and occasionally when they're having additives to those fluids, but it's not specifically for IV medications. That is for the medication chart. You need parenteral route administration medications to be checked by another nurse. Just look out for either paper-based prescriptions of fluids and medications as opposed to EMR. So if you're using EMR, there might be e-fluids and e-meds for that. We always check the fluid for any contamination and faults or tears or leakages in the bags. We have our 5 rights. When you're going on placement as a student, make sure it's 2 nurses plus you that checks. If you're the one who's leading the procedure, you need 2 other nurses supervising. 1 nurse to supervise and another nurse to double check. We want to check that the cannula is patent, so we check around the site. A way that we can check patency is to what we call flush the cannula. And flushing the cannula is when we get a 5 to 10 ml syringe, draw up 5 to 10 milliliters of normal saline for injection, and swab the cannula and directly connect it to the patient's cannula or IV infusion set and inject that fluid into their cannula. And if there's a lot of resistance, then it's probably blocked. If the area around the cannula starts to become wet or swollen, then we can probably assume that it's tissued, and in either of those cases it's not patent, and you should continue to use it. We inspect the insertion site, report any abnormalities. So remember, we are looking to see if there's any localized redness or swelling, or tracking up the vein. We are feeling for any localized warmth or coolness or leakages, whether that's fluid leaking or blood leaking. We control the rate flow as prescribed and as per our accurate calculation that has been checked with a second nurse. We want to monitor the condition of the patient, record any changes. Remember, we want to come back and assess our patient and the infusion every hour. Maintain accurate records. All details of the prescription and calculations are checked by 2 nurses. And the students you all as students have medications that are supervised by an RN, not just the injection. So with 508.2, how you were administering oral medications on that placement, that will still continue under supervision. So at all times you would have been supervised doing that procedure for 508.2, and on your placement for 508.4 it's the same. Any medication, it's always supervised by a registered nurse. The Australian Injectable Drugs Handbook is your friend. It's there to help you. It will tell you how your medication is prepared and how you can give it. We follow the directions as if it's following a recipe, and really, if you have any questions about how to interpret the Australian Injectable Drugs Handbook, please just ask. We're here to help you with your learning. But lots of practice as well is going to help you prepare for the end of semester CPA. Always check your compatibility of solutions and medications, which is something you can check in the Australian Injectable Drugs Handbook. We never add medications to blood products, though blood products, the administration of blood products you don't do until next year in 6019, which is high acuity nursing. We always accurately label our medications and our fluids as per the national guidelines. So just to recap, our 5 rights is right patient, right fluid, right volume, right route, which will always be IV in this situation for this procedure, and right rate / duration. So if it's 250 mils over 4 hours, or you've converted your mils per hour to drops per minute, that's part of that right. Things or factors that influence flow rate. Have a look, if things aren't going well and you're trying to troubleshoot, have a look at the height of your IV pole and your IV solution that's hanging there. Maybe you need to just raise the height of that a little bit more if it's a gravity set. Have a look if your roller clamps are still completely closed, sometimes, or maybe they're completely open. But sometimes students stand there and think, why isn't it flowing? Because one of your clamps is still on. And that honestly happens to me sometimes when I'm at work and I popped the infusion giving set into the machine and I press start, and then it beeps at me and tells me that there's some kind of occlusion. It's because I haven't opened the clamp after priming it. Have a look at the position of the cannula, where it is. So maybe it's sitting in the cubital fossa and the patient keeps bending their arm. The size of the cannula, because it does come in different gauges, that can also influence flow rates. How patent your tubing and your cannula is, if there's some kind of kink in the tubing somewhere along the line. What the condition of the vein is like. If the cannula has tissued or is leaking, and also how viscous the fluid that's being administered is as well. So if you're not really sure what's happening and why your infusion isn't running well, have a look for any kinks in the tubing. Maybe the actual cannula is actually sitting against the vein wall, and so that's why it's not really, your fluid isn't flowing through very well. And just look at the condition of the cannula, which we can also term as a vascular access device, because we're accessing the circulatory system, we're accessing the vascular system. So have a look if it's patent, if it's not running well, maybe it needs to be flushed with, as I said before, 5 to 10 mils of normal saline. And then always assess the cannula site if, maybe it's just not working well anymore, it needs to be removed and replaced. When we're discontinuing the IV, so we need to just check that in the patient's records that we are actually discontinuing the infusion. And if we can actually remove the cannula, so here in the image you can see that hub on the one end and the actual piece of flexible tubing that's been sitting in the vein. We need to be maintaining asepsis, so make sure that you wear gloves, make sure that you don't come into direct contact with your hands to the exposed site. Place some gauze over the patient's, over that site after the cannula has been removed. Apply some pressure, for a couple of minutes, and observe for bleeding before you take completely remove the pressure. So apply some pressure onto the site where the cannula has been removed. Check it to see if it's still bleeding after a couple of minutes. Do you still need to apply a little bit more pressure? Is the patient on anticoagulants, so they clot a little bit slower? Do you need to apply pressure for longer? And then once it's okay and it's not bleeding anymore, you get, you leave the piece of gauze on top and you put some tape over the top as well. And some of you might have seen that being done on clinical placement earlier in the year, maybe last year if you're a combined degree student. And we always document in the fluid balance chart and in the progress notes for when any fluid has been administered. So in summary, make sure you do your 3 checks of the 5 rights. I can't emphasize that enough because it's part of what you're doing for your CPA, and we know that the 5 rights checks and the 3 checks of those is a non-negotiable. It has to be done. We do it before preparing the IV medication / priming the IV line, after preparing the medication / after priming the IV line, and right before administering the medication or the fluid to the patient by connecting it to the, right before we connect to the patient. Just depends if you're only giving IV fluid, which will be the one on the right, and if you're giving IV medication in IV fluid, then it's these ones on the left. So before preparing, after preparing, right before administering. If you're just priming the line with fluids only and no IV medication, it's before you prime, after you prime, and right before you connect it to the patient. Do your calculations for mixing medications and your rate of infusion before you start. So I think try and get that out of the way so that every check of the 5 rights, each one of the 3 checks, you are able to check that your calculation is accurate. Use aseptic technique for spiking the bag and connecting to the patient's cannula. During and after priming, make sure that there are no bubbles in the giving set. So remember that flicking of the IV tubing. If it happens in your sim labs, that's kind of a good thing in a way, because then you can get feedback from your tutor as to how to do it. They can show you how to do it, give you some tips to help get air out of the line. So you'd rather have that instance during your lessons over the semester rather than it happening to in your CPA and you never had that situation before. So I think make sure that you ask about that over the course of the semester in the labs with your tutor. IV fluid and IV medication accuracy of administration. This comes down to how you prepare your calculation and how you're going to ultimately administer it through the regulation of your flow rate. And that takes us to the end. Thank you so much for your time. This is a big skill to learn. It's a new skill. We've started off in week 1 covering this content, and we're going to build on it throughout the semester. So it's a lot of theoretical content now. It's a lot to take in, a lot of procedural videos. But really, we're here to support your learning so that you're better prepared for clinical practice, because that's what it ultimately comes down to, how you are with patients and whether you're able to do these procedures accurately and safely. So please ask questions, clarify any concerns that you have, or any misunderstandings that you might have we have the whole semester to prepare, and we're here to help you do that, the whole team. Myself, Michelle, Jill and Dawn, we're here. So ask us in class, email us, or place something on the discussion board, which we're keeping an eye on and respond to as timely as we can. So thank you again, and I'll see you later this week.